Good morning, ladies and gentlemen. Welcome to the next plenary, which is going to be very interesting because it's on an ethics issue. And personally, I'm very pleased that there are now increasingly ethics issues also discussed in our medical conferences. Our speaker is Dr. Arosha Disanayake, who needs no introduction, but a short CV is paid in there. But personally, I could tell that Arosha is a person who will, in his talks, will no doubt stimulate our thinking and maybe even trigger some discussion and debate during lunchtime, because he's both a good speaker and a thinker. So without any further ado, may I invite Dr. Arosha Disanayake to speak to us on to do or not to do ethical dilemmas in end-of-life care. Arosha.
Good morning to all of you, and thank you, Chairperson, for a very generous introduction. This morning we're going to spend a few minutes looking at ethical dilemmas which we would encounter towards end of life. Now, end-of-life care is the business of everybody. It is not that of the palliative care physicians only, with all due respect. So as physicians, we will have patients who will have chronic incurable illnesses. And then, of course, we will see them die in the wards, or we may facilitate their deaths at home. By facilitate, I mean we care for them during their dying stages. And then, of course, it is important that all of us be competent and confident and be aware of the multitude of issues that would constitute end-of-life care. And this morning I've taken one specific area in that process, looking at the ethical dilemmas that we might have to face towards the end of life. Now, the job of a doctor is usually very simple. We are there to do only two things. One is to relieve and cure patients from their illnesses so that their symptoms will go away, they will feel better. And we call that reducing morbidity. Then, of course, we are there to treat patients so that the deaths are, unavoidable deaths are postponed, or, we ensure that patients live full valued lives. So in general, that's our duty, just two simple duties. And if all goes well, then there are hardly any ethical dilemmas that we will face in the ordinary course of events. But as things are not so simple, especially towards end-of-life care, there are different dilemmas which we have to deal with. One of the most important thing is, at the very end of life, very often the patients lose that capacity to take informed and considered decisions. Immediately taking decisions on behalf of their welfare falls upon two parties. One will be you as the doctor, and the second party will be, of course, the family members who will be the carers for the patients at home. We must bear in mind we are not an individualistic society like some of the Western countries. We do not have an established social support services where social support will come and look after people. We have what's called an intergenerational care system where the children look after the parents, and they in turn will be dependent on their children in time to come. Of course, this entire system is being challenged at this moment of time due to urban migration, dual learning households, etc. But still, that is our system of support for people who are unwell and elderly. And it is a wonderful system. And we must do everything possible to preserve that system while supporting where the system will be falling. So we need to think about capacity to take decisions. The patient is very often unable to take decisions. Then, of course, now in my friend Professor Madagama very clearly outlined the clinical benefit of using some of the medicines in diabetes, SGLT2 inhibitors, etc. Now, when it comes to end-of-life care, some of the very evidence-based, some of the very fundamental forms of treatment that we have, for instance, cardiopulmonary resuscitation, which we would invariably do in every patient who has maybe a cardiac arrest in the ETU, the value of some of the very fundamental forms of treatment are uncertain. That causes problems for us. Then, of course, we as doctors, we've never been trained to deal with death. We've been trained all our lives to deal with patients who are ill, and we try our level best to get them better. It is only at forums like this that we look at the other aspect of it, that's caring for dying people, and very often, because of our lack of training and the way we perceive the practice of medicine, we consider deaths of patients as personal failures, and we feel bad about that. So it's emotionally difficult for three parties. It's difficult for the patient because patient has a lot of uncertainties to deal with. It's very difficult emotionally for the family. It's emotionally difficult for the doctors as well. Of course, we can't give up. We need to find our way through this medical, legal. Now, unlike many other places, many legal issues come up in end-of-life care provision. And then, of course, ethical quagmire, we need to find our way in this process. So let's look at how we can possibly do that. Now, looking at the principles of medical ethics as laid down by Buckham and Childress in their wonderful work, Principles of Biomedical Ethics, we do, of course, they only summarized it, we knew all this before that as well. There is a duty of beneficence in the end-of-life care. We usually treat patients to cure illnesses and relieve suffering, but in end-of-life care, we need our objectives change towards creating what's called a good death for the patients. Whether death can ever be good or not is a philosophical question that we can discuss on a later day. But then we have what we perceive as a good death, and then of course we need to create an environment of a good death. So what would be a good death? These are some of my thoughts. One is, of course, patients, and when we die, we need to die in a comfortable environment. Environment in the sense we must have some privacy, comfort, maybe light, maybe having the presence of loved ones around us. The entire environment is important to create a good death. Of course, this will be difficult in the current ward settings that we have, but that's something to think about. Then, of course, the patients need to be free of physical symptoms such as pain, nausea, and breathlessness. Those are the three most important symptoms that need to be dealt with in providing end-of-life care. They need to be free of distressing psychological symptoms such as anxiety, distress, depression, agitation, all that. Then, of course, another very important aspect is they need to be free of delirium. They need to have their minds as clear as possible to the last moment so that they know that they are being cared for by their loved ones and the doctors, and any problems that they can have, that they feel any discomforts, they can speak about the difficulties that they have and seek some support. Then, of course, we have spiritual needs, and the patients who die a good death should feel spiritually supported in whatever way that they perceive as being important to them. I'm not for a moment saying that every dying person should have pirit from recorded from a MP3 player stuck in with earphones stuck in the ear. I'm not suggesting that. Of course, we need to find what spiritual support that the patients would have, and then, of course, felicitate that. So this is the duty of beneficence that we would have towards an end-of-life care patient, and this is fairly straightforward, or not all that many dilemmas really. Then of course, we have a duty not to harm, non-maleficence. This is where the problems start. Our usual objective is to prolong life. I mean, that's what we do every day. I mean, that's why we give SGLT2 inhibitors to patients with diabetic kidney disease, to prolong life. So in end-of-life care, we need to see two aspects. On the one hand, we do things to prolong life, but at the same time, we must ensure that we are actually prolonging life, but we are not prolonging the dying process. That is the very subtle distinction that we need to make. That's where all your judgment as experienced clinicians will come. The question to be asked always, are we prolonging life or are we prolonging death here? Is it really worthwhile prolonging death anymore? Now, these are the contentious medical treatments. Now, most of these, for instance, nutrition and hydration, it is a moral and an ethical duty of the patient, medical duty of the doctor to provide nutrition to the patient. You have to ensure the patient is well nourished. But such fundamental treatments become contentious in the scenario of end-of-life care. Mechanical ventilation. We need to think again, is that the way forward? Cardiopulmonary resuscitation, is that the way forward for that patient? Clinical nutrition and hydration, is that going to contribute to prolonging of life, or is it going to contribute to prolonging of dying? Withholding or withdrawing treatment. There is a subtle difference between these two words, but we will talk about that later. For now, withdrawing is what the patient is already on. Withholding is not commencing. Now, we know that patients with, for instance, renal failure will have renal dialysis. Is this patient who is at the end of his life, should we give renal dialysis for his renal failure? And then, of course, terminal sedation, where we actually sedate the patient when we run out of options to relieve symptoms. When we can't relieve the symptoms, we go for sedation of the patient so that at least he will not feel those discomforts. So these are the contentious medical treatments that we will need to very briefly look at to see what is the way forward. These are the dilemmas that we will face. Cardiopulmonary resuscitation is a life-saving procedure in usual course of medical practice. But we must remember that every single medical procedure has three aspects to it. Three. One is we do things with the hope that it will have some benefits. Along with the benefits, there will be some risks. So we will always ensure that the benefits will outweigh the risks. In addition to those two, there will always be a burden with some procedure. Burden, in the sense, whatever the for instance, a simple example, the benefits and the risks of a COVID vaccination is, there is a burden of having to go there, having to stay in a queue where you might actually get exposed to other COVID patients, having an injection which is going to be painful, whatever the benefits, whatever the risk, that burden is there. For instance, if somebody has a CPR, I mean, forget the risks and the benefits, but that whole process is going to be anyway traumatic, even if the patient survives. For the relations, it's going to be, so the burden of any procedure we need to keep in mind. So all of these things we need to look at from that aspect, the benefits, the risks, and the burdens. Now, in deciding on cardiopulmonary resuscitation, the important consideration that is recommended is the patient likely to survive through this process? Survive not that cardiac arrest, but will that make the patient survive this illness, or will we be able to make a good quality difference, a quality difference, not quality of life, but a good quality difference to the outcome? Are we able to change the outcome of this illness? And it is considered often inappropriate in end of life. Then, of course, mechanical ventilation. It helps to overcome respiratory failure in the usual course of medical practice. In the patient at end of life, again, we need to find, is this in the best interest of the patient? Will it reduce unbearable dyspnea, or will it merely prolong his death? Clinically assisted nutrition and hydration. This is an essential part of human flourishing, and this is probably the most emotionally and ethically challenging decision that doctors have to make: clinical hydration and nutrition. Involves giving food and water to patients who are unconscious or unable to swallow, and we may consider enteral parenteral. This is where much social considerations come in, because the families in our cultural setting will want till death some nutrition provided to the dying person, and that is not an unreasonable request. That's a centuries-old belief about how human life is. In terms of evidence, there is no clear-cut evidence that actually clinically assisted nutrition and hydration either prolongs death or prolongs life. In all probability, it has no effect on the ultimate outcome. So if you look at the medical, we don't know, so you can take either path, but we don't live in medicine alone, we practice biopsychosocial medicine. So when it comes to social and psychological aspects, you will have to make a considered decision which is going to be comfortable for the three parties that I mentioned earlier: you, the family, and of course, most importantly, the patient. Then, of course, withholding, withdrawing other life-prolonging treatments such as antibiotics, dialysis, ECMO. Again, we need at every stage to assess the chances of survival. Are we prolonging life? Are we prolonging death? With continuation of these measures. Terminal sedation, as I told you, is for the patient who is in the last few hours. If the patient is having symptoms which you can't control with the medicines that you have, and the patient finds it very difficult to tolerate, we can go for terminal sedation using benzodiazepines or opioids, etc. There is always a risk. There's some evidence to support that also. If we go for terminal sedation, the patient might die earlier than he would if he's left alone to suffer with the symptoms. So you may actually, it's not active euthanasia, but with terminal sedation, which is medically indicated to relieve the symptoms, the net result might be that there is a very brief shortening of the line, which might actually be a good thing. You will shorten the dying process. Now, we spoke about the duty of beneficence and duty of non-maleficence. Then we come to respect for autonomy. Now, this autonomy is very interesting. Autonomy is that the belief that the patients have a right. Thank you. Thank you very much. Is the belief that the patients have a right to decide on three things. One is to decide upon, it started off with giving consent for very different types of treatments, and now the autonomy has expanded to include receiving information about illnesses as well as prognosis, information about the prognosis of the illnesses. Patients often lose capacity towards their lives, and then thereafter they will not have autonomy. Therefore, whatever decision that the other parties make with regard to the patient has to have two words: best interest of the patient in mind. If at any time your decision is challenged by somebody else in a court of law, And the court of law, in the absence of any legal provisions, will look at whether you have acted with the best interests of the patient in mind. So those are the two key words if the patient is lacking in capacity. Now, in Sri Lanka, one of the major problems that we have is in England, there is something called the Mental Health Capacity Act of 2005, which clearly lays out if somebody does not have capacity, what needs to be done, who gets the decision to have capacity, to make decisions. But in Sri Lanka, there is no such legal provision. So if the patient loses capacity, nobody knows to whom, if at all, that power passes. Now, in the very individualistic kind of societies like England, it is considered to be the most individualistic of societies. It's not my opinion, but there is a beautiful book on the rise of English individualism by Alan Macfarlane. And of course, it's colonial offspring USA. They are very individualistic societies, so they talk about patients and doctors. But in other European countries, continental countries, in the Asian countries, it becomes a triad. And this is what's called a relational autonomy, which has been proposed for Asian countries, or at least countries which have different views of it. And then, of course, in communicating bad news, in deciding upon what would be futile treatment, if the patient is lacking in unable to give consent or lacking in capacity, we need to get together with the family and make decisions on behalf of the patients. And it is not clear who gets precedence. Now, there is the duty of fidelity, which is truth-telling. One of the questions that is asked in exams is like, if you have a diagnosis, are you going to discuss with the family first, or are you going to discuss with the patient first? And then, of course, with the MRCP examination in mind and with that training that we all have, our first instinct is to say, I will disclose the information to the patient, and then with his consent, discuss with any other family member. So this is the one other dilemma that we need to face. Which way do we go? There is a lot of literature which has been written on transcultural ethics. And of course, in individualistic countries such as UK and USA, it is very patient-focused. But literature from Japan states that it's very family-focused. Doctors will break the bad news of a cancer or dying, anything to the family, and then discuss with them the best way to get this information across to the patient. Should it be the doctor who says it? Should it be a trusted, loved family member who says that? Because what we need to understand is autonomy was not brought about to keep the family away. Autonomy was brought about to keep patient coercion away. Now, patient coercion is maybe very occasionally seen in our societies, but maybe 99% of the time, the families are not coercing the ill person, but they are supporting and loving and taking care of the ill person. So, and also if you look at countries like China, their structure is that the families and the patients will leave the decision making as to what should be done, what should not be done to their doctors. So there are different models. Our model is probably closer to Japan than any other place, I feel. But we haven't defined these through our own transcultural studies. In Japan, there have been court cases in which the families have challenged doctors who actually broke bad news to the patient straight away and caused distress, because they say the family wants to protect the ill person from the devastating effects of bad news. And they feel that they would be able to much better handle that than the doctor would be. Now, we often get family requests for non-disclosure. You all have all, I'm sure, have come across where the patient sits and the relation says, "Amma danne, tata danne," kind of thing. They have not disclosed and they will make requests for non-disclosure from you. So how do you handle such a dilemma? Do you say, as some candidates say in the MD exam, no, there is something called autonomy. I cannot do that. I have to tell your father and I will tell your father. That will be very useful for the MRCP exam and maybe for the MD exam as well. But in terms of your dealing with the patients under your care, it's much more complex than that. My thoughts on this are, and some other people who have written on this subject, the thoughts are, first thing is we need to understand the family's point of view. Why are they worried? What seems to be the problem? Can we address their concerns? Because we need to avoid an adversarial relationship with the family in instances like this. Then, of course, we need to gently explore with the patient his preferred method of receiving information and the amount of information that he wishes to have. There's a concept called truth dumping. You just sit the patient and say everything you want, including prognosis and everything. That's called truth dumping. That's not autonomy. That's not respecting patient's autonomy. Patient has a right to hear what he wants. Patient has a right not to know what he doesn't want to know also. So truth dumping is far from autonomy. And then, of course, we need to take time and have what's called an incremental approach to resolving requests for non-disclosure. Incremental in the sense we need to progressively build trust and relationship with the family, because there is nothing to say that any bad news, including news of impending death, needs to be broken by the doctor. It can be the most loved person in the family. So we need to be incremental in our approach to do this. Then, of course, advanced directives and health proxies. It is good practice to discuss with the family what the patient's thought had been on, say, for instance, being fixed to a machine where they want to die, etc. But you must remember that advanced directives have no legal recognition in Sri Lanka. We don't have any such legal provisions. And of course, there is euthanasia and physician-assisted suicide. That's beyond the scope of this lecture. I don't think that it will come in our lifetimes to this country, where I think even homosexuality is still illegal. And in terms of withholding and withdrawing treatment, removing the plug or not fixing the plug, is there a difference between these two? I was in a symposium several years ago with Honorable Justice Yasantha Kodagoda, who is a Supreme Court judge now. He was the Solicitor General at that time. And he would say, he told that audience, do not remove the plug from a ventilator because you can easily be held liable for manslaughter under the laws of this country. So withdrawing treatment, whether withholding treatment is any different, we don't know. In Sri Lanka, unfortunately, this is a legal territory which is still uncharted. There are no laws with regard to this, either laid down as acts or case law. So if ever such a challenge comes to court, then of course that will be the first case law, and they may take persuasive evidence from, say, English law or Roman Dutch law, but at the moment it's a legal hiatus. So in terms of uncertainties, where are we in terms of provision of end-of-life care? We are uncertain about what constitutes a good death in our society. That's where we must direct our research. What a good death means to our people. What are the clinical benefits of some life-prolonging measures? That's a global problem. Nobody knows the answers to some of these questions. Then, of course, we have uncertainties about families' role in decision making. What I've tried to say is that we should not adopt the individualistic approaches of some of the other countries to our country, but we need to define our own, looking at similar cultures world over. And of course, the legal lacunae and the uncertainties on how judiciary will respond in a legal challenge. We just don't know. Even if we write, do not resuscitate in a ticket. And if somebody were to challenge that, we don't know how a judge would take that in the Sri Lankan legal setting. We just don't have any precedents at all. If they adopt English law, look at English law and give a judgment, that might be good, but if they don't, we just wouldn't know. So we need to be very careful. So my last slide, what is the way forward in resolving the dilemmas that we face in end of life? Regulatory authorities like SLMC and professional organizations need to provide ethical guidelines. Yes, ethical, but then we must remember that ethical guidelines are not law. So we can still be challenged, even if the guidelines are there. What we must really push for would be proactive enactment of legislation to protect both patients and healthcare supply providers like doctors. So the doctor's dilemma in the 21st century, Bernard Shaw wrote about dilemmas of a doctor a century ago. The dilemmas have changed somewhat to us. For us it is to do or not to do many things. And that is the question, as Shakespeare says in Hamlet. Whether it's nobler in the mind to suffer the slings and arrows of outrageous fortune, or take arms against a sea of troubles. May I suggest that we do not suffer, but we take arms against a sea of troubles. Thank you.
Thank you, Dr. Arosha, for those sharing those thoughts on a less discussed field of patient care. Let me thank again on behalf of the Sri Lanka College of Internal Medicine for this excellent talk. And please accept the appreciation in the form of a token.